right, gang, it is Wednesday. It's Hump Day. Welcome to Dennis in the Know. This is your backstage pass for current trends, politics, and education in the dental world. It is live and it is over a beautiful glass of red for me. JB, what are we having tonight? I saw something. Let me guess. Sauvignon Blanc?
Of course. It's a day that ends
Yes.
in Y.
Very nice. Anyway, it is live and it is over a cocktail. We encourage your banter. As you know, I am always here joined by my compadres, Jennifer Bell, Dr. Jennifer Bell, otherwise known as JB. Unfortunately, Chad couldn't be here tonight. We're sad about that. He's actually over at the vet with one of his animals. So we wish he and his wife, Ellen, who is also celebrating a birthday today. And if you ask me, that's a lousy way to celebrate a birthday. But we certainly wish Ellen the best and Chad, and of course, their fluffy friend. We hope everything works out well. Anyway, we are all educators, we are all business owners, and we are all practicing dentists. Our job is to bring all of you in the know, and we hope to have some fun doing it. Tonight, we have a great friend of the Dinks, a great friend of Dennis in the Know and Humpday Happy Hour, and that is Tom Viola, our friendly pharmacist friend. And he is just a brilliant mind, a great lecturer, and someone who has really been able to enlighten us on a lot of topics and pharmacology and how it relates to dentistry. So we're really excited to have Tom with us again. And what I'm going to do now is turn it over to JB. I'm going to stop talking because then I won't have a delay. We'll let JB give you the news and then we'll refresh her and see if that delay doesn't go away. JB, you got some news?
Of course, always. That's my job, Jeff, that I do for free every week for everyone else's benefit.
Yeah. Well, yeah, none of us are really making a killing doing this, are we? Yeah. No one's laughing their way to the bank, are they?
Nope.
All right, I'm dropping out. Do the news.
Okay, you got it. Well, we are in the season of governance, and so there is some activity for dental news happening out there, but not a ton. So as you know, the ADA got together over the weekend and finished installment of officers just early this week. So it's been an active time for the American Dental Association. Lots of resolutions were discussed. I'm still hoping and waiting to get further information. There's a few in particular that I'm very interested in as we head towards the AGD governance session, which is happening in mid-November. So this is the season where most dental organizations are getting together, making decisions and looking at policies and procedures to understand better how to move forward and to keep our organizations that are supposed to serve the needs of their members well. So hopefully we'll have additional good news to report. But lots of great officers were installed. The ADA is continuing to move in a positive direction. And we'll just wait to see what comes out of the House's decision. I'll keep you posted as soon as I know. Other news that came up is completely outside of dentistry, but I think relevant to most of us. And that was the decision that the government made just yesterday to modify the tax brackets slightly related to inflation. So if you haven't discussed this with your CPA yet or didn't know that it happened, I certainly would encourage you to do so. They have actually upped a lot of the tax steps as they go along in about a 7% adjustment to relate to the current inflationary pressures on income. That being said, the one thing that I did observe in some of the articles that I think is worth noting, for your taxes in 2023, itemized deduction opportunities may be modified. So it is definitely worth a discussion with your CPA, both first to see where you fall within these adjusted tax brackets and if you need to make any adjustments from that standpoint. But in addition, if itemized deductions are going to be modified, it could change your tax liability as well. So it looks like this could be a bit of a moving target, certainly for most dentists who are often affected by these changes, sometimes in a not so positive way. I definitely would encourage an additional quarterly visit with your CPA to discuss how these changes are going about. I would say give them just a little bit of time, as this was just announced yesterday, but certainly something that is going to need additional attention. There was an article that came out this week in JAMA, the Journal of American Dental Association, talking about, or JADA, talking about dental healthy therapists and their effects and impacts in Alaska. I do think this is an interesting read because it talks a lot about how dental healthy therapists have been a positive additive to the dental workforce in Alaska, and that they've been able to serve the needs of communities that were currently underserved. And this is an interesting take because we have continued to evaluate dental healthy therapists and their potential role in the dental professional tiered community. And are they an added benefit or not? Many of the articles and research studies that came out from other countries that had added mid-level providers did not necessarily present the outcome in a favorable light. So it is worth looking at the Alaska study to say, is there something unique about Alaska that makes dental healthy therapists more effective in that particular community? Is there something they're doing right that has made that more successful? Is the data accurate to correctly reflect what is happening in those communities as compared to the communities that we saw in New Zealand, for instance? So I think it does warrant some additional investigation because there is a lot of pressure and a lot of potential legislation that is being proposed for mid-level providers. I know we've been talking about this for, I don't know, going on 10 years now, looking at what a mid-level provider might look like for the dental profession. And there's been certain studies and white papers that have been drafted both by the ADA and the AGD, looking at the impacts of mid-level providers to our profession. I think this Alaskan study is the first contradictory research article that we've seen compared to the other articles that have come out from other countries that have introduced the mid-level provider. So I think this is certainly a chance for us to continue to look at the science and research more into those communities to find out what makes each of them unique and why in this particular scenario it's been deemed successful. And with that, that's the news.
All right, I'm coming back. So, JD, any mention of what might happen with the 179 deduction expense? Because if there could potentially be some changes to the 179 deduction, because that's been really the big tax advantage for most dentists in being able to buy equipment at the end of the year, then would it not be prudent for people to really get some equipment this year as a tax strategy? Just curious what your thoughts are on that.
So it doesn't look like they've dealt with anything related to corporate tax deductions, which would be things like the Section 179. There was also the Section 139, which was unique for the COVID years, where you could write off additional things that you were having to do. For instance, if you were having to homeschool your kids or provide virtual support, or hire someone to come in to help you educate your children because they were unable to return back to school. There are some unique deductions available to corporations, S corps, LLCs, et cetera. That doesn't seem to be what's impacted. These are basic standard deductions that seem to be more impacted. So if you're writing off charitable deductions, medical expenses, those types of things might be impacted by mortgage interest, tax payments, etc. Those are the standard deductions that I think could be impacted by this current modification of the tax law. The other thing that is going to change, flexible spending accounts are going to go up. Earned income tax credit is also going to go up. Gift exclusions are also going to go up as well, and estate tax limits are going to be adjusted too. So it seems to be more focused on the personal tax income side, which would just be your pass through from the advantages you can take from a corporate perspective.
Let's just keep you on, and let's bring our good buddy Tom Viola up. And this guy doesn't need an introduction. He's been lecturing on pharmacology and how pharmacology impacts the dental profession for years and years. He's a great friend. He's a smart guy, and he's also from New Jersey. So score one for you. By the way, are you a Giants fan? I think we talked about this, right?
I am a Rams fan, so you can't get any more Rams fan than me. So sorry.
Well, thanks for being here, Tom. It was good talking, and wish.
That's so funny.
Your Giants are doing pretty well this year. I might have to.
Yeah, well, Giants are doing pretty lucky this year, is what seems to be happening. So we'll take it. If you can't be good, be lucky.
I agree. So it's all good.
Yeah.
We'll take it.
So how you doing? What's new in the world of pharmacology? Anything you want to talk about? You're a friend to our group, so spit it out and let's just rock.
Well, thank you so much for having me. First of all, it's always a privilege to be with you guys, and I enjoy very much my time with you. I'm sorry Chad couldn't be here tonight, but it's great to be with JB and Jeff. What can I say? You keep things rolling. I've got a lot to talk about tonight. It all depends on how much time you want to devote to each topic, but I'd like to talk a little bit about antibiotic prophylaxis again, just to kind of hit it one more time. We want to talk about clindamycin and some of the misinformation.
I don't use them.
No. Yeah. Good. Okay. What? Patients don't need antibiotics. Come on.
I'm kidding.
Suck it up. Well, of course, we're going to use antibiotics both appropriately and, of course, when necessary. But there's a lot of misinformation about clindamycin, and it seems like since the American Heart Association put out its recommendations last May 2021, a lot of people thought that meant that we should stop using clindamycin altogether in the practice of dentistry. Mm-hmm. And that's not really the case at all. As a matter of fact, clindamycin is one of our best tools in the tool belt for treating types of infections that amoxicillin just can't touch. So I wanted to touch on that a little bit and let you know that if you're out there and you heard about the guidelines being proposed and then finally passed by the American Heart Association that indicated that clindamycin is no longer recommended for infective endocarditis prophylaxis, that did not change the stance of the practice of dentistry on the use of clindamycin. Yes, clindamycin can cause C. diff-related infection and C. diff-related diarrhea and other complications, and it could be life-threatening. There's no question about it. But the incidence is very small, and you really do avoid a lot of that potential. From everything I've read and what practitioners have told me, if you go short, no more than 7 days with the clindamycin, and usually that's about all you need to treat most infections.
Yeah. Now, how does that compare with azithromycin? Why don't you tell us some of the differences between clindamycin and azithromycin, and why they've kind of moved azithromycin in and are backing clindamycin out to some degree?
Well, to be quite frank, I think we may be perhaps the last profession that uses clindamycin on a regular basis. Even dermatologists have given up on clindamycin for the most part for routine prescribing for what we call routine infections. That's not to say that it's not used in urgent care settings, hospitals, and so on for infections that are where we've done a culture and sensitivity. But in general, we're one of the last professions that actually prescribe clindamycin for routine infections. Now, the American Heart Association says we should not be using clindamycin because at this point, they feel the risk outweighs the benefit. Clindamycin is one of the last in a group of lincoside antibiotics, which lincomycin was the first. But its spectrum is perfect for dentistry. It really does have great efficacy against the bugs that we normally encounter in the mouth. Azithromycin is a macrolide antibiotic, which is a different class altogether. But the American Heart Association and some docs out there, some practitioners that I've met in my travels. I was at the ADA meeting this week, and there were a couple there as well who told me they use azithromycin religiously. And I said, well, why? You know, what's the catch? Why azithromycin? And their point is, well, azithromycin is not of the same class of penicillin or amoxicillin, so that the threat of allergic reaction is remote, if at best, and it has the same spectrum for the most part, and it does a pretty good job. Plus, you can prescribe a Z-Pak with confidence in patients where you're not sure if there's a penicillin allergy. All well and good, but remember that azithromycin has been linked to arrhythmias, both atrial and ventricular arrhythmias, in patients who are predisposed. So the thing is, would you know if that patient's predisposed? It's hard to tell as a dentist when you're taking medical histories on the fly and maybe have 5 to 10 minutes to devote to a medical history if that patient truly has an issue. And don't forget, we use drugs in practice every day, local anesthetics and epinephrine, that increase the risk of arrhythmia. So azithromycin is not a bad drug. I don't want to give anybody that impression, but if I had my druthers, I'd still use clindamycin because it's really the devil you know versus the devil you don't. And I think clindamycin has its risks, but so does azithromycin.
And what is the incidence? Because we heard about, you know, a lot of the arrhythmia concern during the COVID thing when people were talking about using a Z-Pak, you know, and you know some other methodology for helping to battle COVID. What do you see as the incidence of these types of arrhythmias? It's an elongated QT or something like that. Is that correct?
Yep, QT
So
prolongation, correct.
yeah,
Yep.
how often does that happen, say, compared to the incidence of someone developing C. diff from prescribing clindamycin?
QT prolongation related arrhythmias are pretty rare versus C. diff related infection that may be occurring as a result of clindamycin use. The thing is, Jeff, how many of those arrhythmias are actually noticeable and reported? That's the problem. So patients can have arrhythmias and not even know it. And that may mean nothing. It may mean that nothing happened, there was no ill effects, but we don't know who's predisposed, and we don't know who ends up getting an arrhythmia and later on develops some complication beyond that. Obviously, C. diff related infection is pretty obvious when it does happen, and again, it can be life threatening. But think about the cumulative use of clindamycin over all these years in dentistry versus the use of azithromycin, and you've got to wonder if there was really something to the use of clindamycin that put so many people at risk. We probably wouldn't be using it anymore. So the fact is, they're both pretty safe.
Yeah, and it's pretty easy to
Tom, can I just?
recognize people. Go ahead. I'm sorry. Go ahead, JB.
Oh, no, that's okay. I just wanted to get a clarification on the arrhythmias. Is that a permanent arrhythmia or is that a temporary arrhythmia based on the medication and then there's a reset? Or
From what I read, it can be both, John. It can be a temporary arrhythmia, but some people who suffer damage as a result of it can have a lifelong issue. But that's, again, pretty rare. And you know, you can tell because if you poll just an audience of people, not just in dentistry, but just average, you know, out there, accountants to construction workers to whatever, and just, you know, how many of you have taken a Z-Pak? A lot of hands would go up because azithromycin as a Z-Pak is prescribed pretty widely in medicine. And if you ask them, okay, how many of you knew or were told that you might get an arrhythmia? I don't think you'd get many hands going up at all. So just because it's not well known doesn't mean it doesn't happen. I think a lot of it may be that it's just not reported.
Yeah. And the point I was going to make is just that it's really easy in most cases to know those patients that are going to be predisposed to C. diff, right? I mean, that's going to show up much more readily in our medical histories. You know, the people with ulcerative colitis and irritable bowel syndrome and, you know, other lower GI maladies. You know, we know that we have to be more careful with them right away. So, you know, it's almost, I would agree with you, because clindamycin has really kept a lot of my patients out of the emergency room, where, you know, let's put this on it, a real heavy dose of it. And if it doesn't resolve, or if things go in the other direction, then go to the emergency room. And it's not until you throw that clindamycin at it that the cellulitis resolves.
Right. And I agree with you that, let's put it this way. Some people do get C. diff related diarrhea and other complications without having any predisposition whatsoever. It just happens. But normally it happens with longer courses of treatment with clindamycin. So to your point, and it makes good sense that we probably would know in advance. But yeah, you can't beat the fact that clindamycin does the job where other antibiotics fail. Just because look, if I had osseous infection, if I had, significant, soft tissue infection, I'd probably be asking for clindamycin as a dental professional, if I wanted something prescribed.
So, Jeff, this is an interesting question given your current side gig that you're participating in. But if a lot of the data and research starts coming out against Clinda, where does that put the liability on prescribers continuing to write? You know, if a few data points start coming out against prescribers using it, even, I mean, we can go back to when everyone said we shouldn't be doing IAM blocks with Septicane. It was going to shut everybody's face down and the whole world was going to end. And now if anyone gets sued for paresthesia related to using Articaine, that those articles still kind of trickle back into the courtroom. So from a liability perspective, Tom, where does this put practitioners?
Well, that's the thing. This is a guideline. Much like the thing with Septicane or Articaine used for inferior alveolar blocks and the potential for paresthesia. It's a guideline from the American Heart Association just for the prevention of infective endocarditis. We have not had a statement from the ADA or the AGDs or any position at all on the use of clindamycin in dentistry, as far as I know of. I mean, if you guys know better, please let me know. We've all been made aware of the dangers of using clindamycin, but there's nothing out there that specifically states in the practice of dentistry that we should not be using it.
It's really, it's so interesting, and it'll be really interesting to see where this goes. And I'm going to lean on you. I'm sure that you've probably been exposed to a lot of legal cases involving prescribing by dentists, and I've been getting called in on more and more defense work on behalf of the South Carolina JUA. And, we've actually had a few cases where the antibiotic prescribed has caused some GI issues. And in my experience, it's really been about informed consent, that the prescriber kind of went through everything they could possibly do. And then it's just, you had to do something. And did you use good clinical judgment when you made the choice to pick the one that you did? There is no perfect medicine in any circumstance, right? So you kind of have to pick the one that has the best chance of having, the fewest side effects, but you can't always predict that. So really, to me, it's about informing the patient of potential risks, what to look for, and that it is a possibility. And really, with most malpractice, there has to be either some conscious ignoring of some standard, like a willingness to violate some well-known standard that other people with similar education to you would not have violated. And so that's been my experience. Would you agree with that, Tom?
I think I've always said the same line over and over when we get to this part of the discussion. Never treat a stranger, right? You never treat a stranger. You always get to know your patient as best you can before you render any treatment. And yeah, there's going to be times when you made the decision that you thought was prudent at the time. But remember, the other analogy I like to use is when the city bus gets into an accident, who's the one person they asked all the questions to? It's the bus driver, right? So at the end of the day, you're driving the bus. So you've got to be able to make the decision and be able to not only make that decision, but give your opinion as to why you made that decision and be able to stand by it. So again, I love having these discussions. Anybody who's listening right now, I'm not telling you to prescribe clindamycin or azithromycin. You've got to make your own decisions. But I just want to make sure we cleared up some of the misinformation out there, because I've got a lot of docs coming up to me saying, okay, I can't use clindamycin anymore. What's next? And I said, well, when did that happen? So I'm glad we had that talk. It was good.
No, great stuff. Well, what else you got?
I got street drugs. Not with me.
Whoa, wait a minute.
Is that an offer to sell, or I'm not sure where this is going now, Tom?
We'll have to take that up after this discussion. But
noted.
I got street drugs.
I got street drugs.
I love talking to you guys about stuff like this clindamycin issue, and also, forgive me, I'm sorry, and also this issue with street drugs that are becoming more and more powerful and more addiction potential, because this is like cutting edge stuff, and that's why I love sharing it with you guys first. So fentanyl has always been an issue. Fentanyl remains an issue. That's something that I don't think we could ever change. I love it when people say, you true prescribers, you dentists and medical doctors and nurse practitioners and physician assistants, where they're allowed, you prescribers contribute to the opioid epidemic. I'm not saying we don't. Certainly, there's enough evidence of diversion that you can make the argument that prescribed opioids have contributed. But to be quite frank with you, based on my time working with law enforcement and the DEA, and it's really fentanyl and heroin that have contributed greatly to the opioid epidemic that we're in now. And now fentanyl even more so, because heroin is just hard to make. Fentanyl is cheap and easy to make, and it's easily transported, and it's microgram doses. So we're not talking about a lot of powder. We're not talking about a lot of drug. And it can be easily mixed with other things to make that other thing something you'd want to buy more of. And so we're starting to see cases now of fentanyl-laced marijuana. Again, according to the DEA, and this is a fact that they've often told me, they believe 80% of cannabis sales in the United States are black market. And I would believe that based on my experience, what I've seen, out there on the street. And I will tell you that a lot of it may be indeed laced with fentanyl, because if you get a choice to buy from, this person or that person, and this person's got not usual kind of cannabis, but this person's cannabis really does make you feel much more euphoria, much more relaxed. You're going to want to use this person's cannabis, not marijuana, not knowing, of course, that it's been laced with fentanyl. So that's something we need to be aware of, that opioid overdose can happen to your patients, even if they don't think they're using an opioid, because of this potential for fentanyl being mixed in with virtually anything at this point. And the other drug to worry about is xylazine. Now, xylazine is comparatively unknown in the United States when you compare it to fentanyl.
Yeah, you just dropped one on me that I am.
Yeah, I gotta write it down. Hold on.
Yeah.
Xylazine, right? But like xylophone with an XY.
Yeah.
So xylazine is a veterinary tranquilizer.
Is it like a benzodiazepine? Is it in the benzodiazepine class, or
no? It's in
usually when I hear zine, that's what I was thinking.
Yep. So xylazine is in a class by itself as a tranquilizer. Again, used mostly in veterinary medicine. It's not approved for human use at all, but obviously it can be used by humans in very small doses. It's known on the street as Tranq, TRANQ, but street names come and go. The point is, it's a tranquilizer for humans in low doses that can be added to virtually any drug, again, much like fentanyl, and it increases the euphoria, but also increases the risk of respiratory depression. So you can imagine if you've got some backyard chemists who are mixing fentanyl and xylazine and cannabis together, trying to get that perfect mixture, unfortunately, what I've seen in my experience is they usually make those combinations and try them out on unwitting people to find out how it went. This was pretty common when fentanyl came on the scene, and we heard stories of people who were dealing heroin who also gave people Narcan to take with them to treat overdose because they weren't sure how that person would react. And so you're seeing that now with these fentanyl and xylazine combinations with other drugs. And I'm just concerned because we have patients that use cannabis. They use it as a treatment for medical conditions. They use it for recreational use, certainly. A lot of states allow it, even though technically you're only supposed to buy it at a dispensary. But the point is, as I've said in many of my lectures, when your patient says, yes, I use cannabis, I don't think they know, and I don't think you will ever really know what they mean by that because there's so many different forms of cannabis, and we don't know what's been laced with what at this point.
So if they're purchasing from a dispensary, is that an equivalent to a pharmaceutical acquisition where a consumer could feel probably safe that that particular dispensary is providing safe cannabis?
Yeah, JB, depending on the state, I mean, most states either have some type of licensing or some type of registration process for dispensaries, and they're bound by basically following certain regulations and rules according to the state that they're in for the production of cannabis for sale. But that, according to my understanding, and I don't think there's any change lately, that's the only legal way to buy cannabis as through a dispensary, even if it is a recreational use state. Once you buy a black market, I mean, there's plenty of those types of cannabis that are out there. For example, if you Googled Trips Ahoy, and I'm not making this up, right? Trips Ahoy cookies exist. I'm sure a lot of people who are listening may know this. Those are cannabis infused chocolate chip cookies that are readily available for sale. Okay, and then you've got gummies, and it surprises me that some people will say, "I don't want to take any drug from Big Pharma because Big Pharma is out to get me." When those drugs are FDA approved as safe and effective, but they'll stick a gummy in their mouth and not really know what its origin is. So I guess what I'm saying is, if your patients are using cannabis, we don't really know what that means, and that means if you are going to use a benzodiazepine for conscious sedation or minimal oral sedation, and if you are going to prescribe an opioid for a patient for pain, and they've basically said, I swear, I don't use anything but cannabis, that may not be 100% true, even if if they're not aware of it themselves.
So, Tom, this brings up a good question because, I mean, one of the things you mentioned was this, the incredibly small dose that's required of fentanyl and how little it takes to become lethal. I mean, we've all heard that there's enough fentanyl in the United States to kill every American 10 times at this point. So what would the advantage be to someone to put this into other street drugs? And basically, I mean, I know this is not even dental related, but this is something that just blows my mind. Why would you put unknown amounts of these drugs into other drugs and basically kill off the people that you're selling to? That's the part of this whole equation that I'm not really getting. And maybe you could shed some light on that.
Yep, it's all about market share, Jeff. If you remember, maybe 15 years ago, heroin was a drug that was only available in the 70s and 80s and pretty much went away. Nobody was ever using heroin. It was, like your grandfather's or your father's heroin. And all of a sudden, heroin came back and made a tremendous comeback because the heroin that was available at that point was so much more potent that you didn't need to inject it at that point. You could swallow it, you can smoke it. So it's all about market share. There's a limited, finite number of people who will use substances. And if I want my piece of that market share, I will have to create a drug that people will want to use. So about 15 years ago, it was, this now much more pure heroin. Now it's more of a slant towards, okay, we've got an established base of people that use cannabis, and it's practically legal. And if it's not already legal in that state, Now I want to get those people to buy my product versus somebody else's product. How do I entice them to do that? I'm going to add these other chemicals to my cannabis to make it a little better. You're right. Got to be careful that I don't kill them, but I got to make sure that I add enough to make it worthwhile that don't want to come see me from now on and nobody else.
I mean, are these guys real chemists that are they true chemists that they can actually do? I mean,
You'd
we
be
see how many
surprised.
deaths there are.
You'd be surprised that, even bath salts, which is, kind of a term from 15 years ago, were created mostly as synthetic cannabinoids in chemistry labs by people with pharmaceutical experience in Australia and East Africa and even Great Britain. So the idea is there are
And I have
chemists.
seen Breaking Bad, by the way.
I'm sure you have, right? There are people who have the experience that are highly sought after, who can make these chemical congeners of fentanyl, and not just fentanyl, but drugs like it. And so the DEA is having a hard time trying to keep track of all of the different substances that are currently being made, because some of them don't even show up on tests.
Will you just and I'm sorry, JB, I'll let you ask another question. I'm so fixated on this whole fentanyl thing, because I remember even in dental school when I would go through the oral surgery clinic, and they would have the chalkboard right there of, what they were planning to give and then what they actually gave. And, fentanyl was always on the board. But with other narcotics and benzos, and I thought, what a mess. Like, you start putting, why do you need that many medications? And I understand propofol hadn't really, it really hadn't found its place yet. It had, but it wasn't commonplace yet. And everyone was doing doing the narcotic benzo combinations to put their patients to sleep for oral surgery anyway. But I guess my question is this: do you really see a place for fentanyl in dentistry or in oral surgery? I mean, is the margin of error that small, or is that something that has really just been ingrained in us because of all the deaths that we're seeing in the general public? So maybe just shed some light on the use of the traditional use of fentanyl in a true medical setting and safety that way. I'd be really curious, for one.
I think fentanyl is a perfectly safe drug to use when used as we said before, when used as indicated for that particular patient for that need. So do I tell doctors who prescribe fentanyl or who use fentanyl in the office for sedation or for anxiolysis not to use fentanyl as an opioid to start conscious sedation? Absolutely not. I mean, it's a good drug to use. It's been used safely for years. Heck, I even remember when we used to use ketamine in dentistry as a dissociative hallucinogen to separate people from the actual procedure itself. So the drugs that we use in dentistry, fentanyl as an opioid, propofol as a sedative agent, and other drugs that we use are perfectly safe. The danger, Jeff, is not what we're using in practice. We are well trained, and if we're following our standards and appropriate practices and standards of care, we know what we're doing. The problem has become that the patient is taking more of the same drugs that we're using in practice in more highly purified forms and dosages, and thereby creating this potential for additive side effects. We're not doing anything wrong necessarily if we're following good practices. It's just the patient has changed over time to a patient who now uses those very same substances, and that increases the risk for us as clinicians.
Can I piggyback on that to say, so as patients may have additional exposure to, let's just say, laced cannabis and other things, then we go to sedate that patient. Today's the day we're going to take out a tooth and we're going to do sedation. I've been in a sedation experience before on a known addict, trying to sedate them down enough to be able to do full mouth extractions. And you couldn't give them enough to get them down. They just kept ping ponging back out, in and out of consciousness. And so for the general clinician who is trying to do light conscious sedation, or like maybe moderate conscious sedation without advanced airway techniques, how do they pre-screen those patients or safeguard themselves? Is there any way to understand the risk profile of these, now what we would have termed recreational, maybe cannabis users or whatever, but they start to pose a real risk for those who are trying to sedate, I would imagine.
Oh yeah, I've heard many stories from clinicians who just try to sedate, just, if you want to just call them, just cannabis users, who end up becoming very combative once they've been sedated, and they actually require physical restraint. Now imagine that that same person used cannabis that's been laced with fentanyl, laced with xylazine, and you find out that when you're using what you consider to be the right regimen of drugs, you've used hundreds of times in other patients, and now they fall more deeply into sedation where their airway may be compromised, and you had no expectation of this in advance. The best thing we can do, JB, is two things. One, again, never treat a stranger. Make sure we know everything about that patient, and make sure they know we're not the police. We don't care if you're using stuff. We just want to know what you're using. Remember, they may not know what they're using. They may think they're just using Joe's, cannabis and have no idea that it's been laced with anything. But then the other thing is, if you really want to be careful, the best thing would be to at least try to mandate that patients don't use any recreational substances for as long as you think necessary. Some docs have told me 48 hours, 72 hours. Some have even said a week, that they want the patient to abstain completely. Now, you can ask. That doesn't mean that they're going to do it. But anything you can do to separate that use of that recreational drug from what you're going to use in the procedure, at least increases, in my mind, the safety margin as best we can.
Well, one effective technique I had when I had a patient one time who had been a known cocaine user prior to, and there is data to suggest the epinephrine and cocaine mixture would not be very beneficial for the patient. And you can embellish that a bit. And I said, now, if I give you this shot, it could kill you if you've had cocaine within the last 24 hours. So did you have cocaine in the last 24 hours? And he was like, I'll come back tomorrow. And he got up out of the chair and walked out. So, I mean, you can get kind of dramatic and say, look, we can do this, but it could kill you. And if you're cool with that, let's go. They'll be real honest with you real fast after that.
I couldn't have said it better. I heard a couple of doctors have come with me over the course of time and said they actually put it in the consent forms. Like, if you've used any substance within the last 48 or 72 hours, be advised that this could be life-threatening. And people read it, and you can see them like pause. They would tell me at that one sentence, well, what do you mean? Can I really die? And I agree with you 100%, JB. That's probably the best way to do it, is to just put a little fear into them and say, look, if you're going to use substances, that's none of my business, but not in my backyard. Don't do it here. But you can only ask. And
exactly.
I
think this brings up a really, really important conversation, because so many dentists, especially more general dentists, getting into implants, and by getting into more surgery, they're also getting into more sedation. And I think that, as dentists, typically, the one thing I've noticed in 30 years of practice is that typically across the board, we suck at informed consent. Like, we're really bad at it. We're so afraid to tell patients that there's a 7% chance that the nerve is going to die in their tooth just because they needed to have a crown done. And yet the dermatologist is okay telling them they could drop dead from the anesthetic injection, to remove a mole. And it's just this thing about dentistry that we think everything we do has to be successful, everything we do has to be painless, everything we do has to be perfect. And so I think this brings up a really important conversation about informed consent, which is, how do we get our patients, like, I loved your technique. That's awesome. But for me, when I would do a sedation consult, I would actually ask my assistant to leave at one point, close the door, or if there was no door on the room, because many operatories do not have doors to them anymore, in a low voice, say exactly what you said, Tom. Listen, I am not the police. I am not here to judge you. My job is to keep you safe. So I need to know if you've been on any recreational drugs, and I need to know that you're not going to be on any recreational drugs within 48 hours. Do I have your word on that? And can I make a note in the chart that you've given me your word on that? And, you know, once I get that permission, I don't even care that the assistant is not in the room. If I have to go, you know, if I have to go one-on-one, I just think sometimes there's a stigma of, okay, these people are judging me, especially when it's 2-on-1. So I mean, it may not legally, it may not have legs, but that's just how I've done it. But I think it deserves a good conversation, right?
Yeah.
On how do we get this information from patients?
2 points to your points, Jeff. Number one, remember that, in my opinion, having been involved with dentists now for almost 30 years, there's this impression that people get that all of dentistry is elective. You know, I really don't need to see the dentist, but you know,
Yeah.
I go to see the dentist because I'm supposed to, but I got to go to the dermatologist because I might have skin cancer. So I get the idea that we kind of shy away from informed consent because it's almost like, well, we're going to push the few people that really want to come see us away, and then we won't have any business. Of course, that's not true, but that seems to be still that the attitude out there is, yeah, I got to go see the dentist. Okay, great. The other thing to your point is you don't want to be the police and you do want to get that note in the chart, but be advised, some of my colleagues have told me I'd rather not know because if I don't know, then I can't be held responsible later if something happens. I think that is a bad way of approaching dentistry. I think the more well informed you are and the more you document, the better, because at the very least, you're showing you a genuine concern for the patient and their well being. And not knowing and not asking is not a way to defend yourself later because anyone's going to ask you, why didn't you ask?
Well, plus you're setting yourself up for the unknown. And I had one true asshole of an oral surgeon attending in dental school. And he was a true, I mean, I have no qualms saying he was an asshole because anyone who's ever met this man would say he was an asshole. But he did say one thing that has really resonated with me throughout my entire career, which is he used to say, and exactly in this voice, if you prepare for an emergency, the emergency ceases to exist. And so I just don't want any damn emergencies. I don't want that. I'm at that point in my career where I'm good without the drama in practice, right? So,
Agreed.
but I think to your point, that's really something that everybody should consider is I don't believe in don't ask, don't tell in practice. I don't see where that benefits anybody.
I think it needs to be on every medical history form. I think it needs to be in writing, and I think the patient needs to sign off on it. If you're uncomfortable having those conversations, and if you've attended my opioid course, you know that's what I say, and I see a lot of people get squirming in their seats when I say it. You have to interview the patient. You have to say to them, do you use other substances? What are they? Have you had an issue with substances in your past? I don't want to ask that question. It's an awkward conversation. Great. Then get it on the medical history form, alter your form to include those things. Have the patient check off yes and no, and have them sign it. And that is their consent, in my mind, to telling you, okay, here's what I know about my history. Should you ask them anyway? I still would ask them, but at least you've got something now to start the conversation. I see you checked off yes on that you've used substances in the past. Tell me more about that. At least that way you've got the conversation rolling. If it says no, but you know, everybody has that sixth sense, like, let me ask anyway. Start the conversation out. Well, it seems you said no as far as using substances. Are we okay with that? Is that, you know, is that something that you read and checked no willingly, or is there something else you want to tell them? Again, even if it's in a low voice, even if you don't want to say it when no one else is in the room, get the conversation rolling, but get it documented, because documentation saves you in the long run.
Mhm.
One thing I do at least like about the fact that cannabis has become more acceptable, et cetera, I have more patients disclosing that openly. Where if I went back 15 years ago and it was still a very taboo substance, you would never see it on a health history. They wouldn't ask you, like, is it okay after this procedure if I resume back to, you know, my normal cannabis use or whatever? You know, it's becoming a more open conversation for everybody to participate in, which actually is really better for all of us to be a part of that. So
the problem, and I agree with you, the problem, JP, is that cannabis has now become so, socially acceptable, politically acceptable, medically acceptable. It's become a vehicle for other drugs. Now that everyone uses cannabis, cannabis is now a vehicle to launch other drug use with. And again, not necessarily related to dentistry, but keep in mind, if you're a parent or a grandparent listening to this, your kids have never had greater access to cannabis than they do now, and thereby never had greater access to other drugs like fentanyl and xylazine as they do now. So, don't be surprised that the kids ultimately may be the victims here, because they're exposed to the same drugs that we maybe take for granted for recreational use, but in their smaller bodies and smaller volumes of distribution, that same drug could be deadly.
So real quick, speed round, because we're just about out of time. But one, I heard a report just this evening that 49% of teenagers have now tried cannabis, which is the highest rate by far ever in our history. So I think, we all have to be aware that it is readily available, and anyone who wants to try it is going to try it at this point.
Jeff, just remember, those are the ones that admitted to it.
Right. What I want to ask you real quick, because I think one of the big takeaways from tonight's show is how important the use of cannabis might be towards their medical history, especially if we're thinking about sedation. So 2 quick questions. One, tell us, if it was just cannabis, what are the risks involved with sedating a patient using just cannabis? And then, of course, what are the risks if it happens, which you said earlier, but a few people on since then? What are the risks if that cannabis happens to be something else, like many of the street preparations are right now?
Okay, so if there is such a thing as just pure cannabis, and we're saying it's an extract, or an oil or a wax or something, or even plant material.
Assuming it's bought from a dispensary.
Right, so just cannabis, right. Then I would say we 2 things we worry about. Number one is getting the patient sedated. Starting the sedation process, I've heard, is a little more difficult for patients because they're a little more resistant to sedatives if they're a heavy cannabis user. And then once they are sedated, they become combative, and a lot of times require physical restraint and maybe even termination of the whole procedure because they become too combative. So that's just if it was pure cannabis and nothing else. Now, if it's been adulterated, and we'll just use the 2 things we talked about tonight, fentanyl and xylazine, then any other drug you use that's an opioid or a benzodiazepine is likely to have an exaggerated effect and response. And so that can threaten the airway, and that can make that whole sedation process an emergency. So that's why it's important to be able to ask the patient directly, do you or do you not use cannabis? And the next question has to be, do you get it at a dispensary or do you get it from somewhere else? And if they say they get it from somewhere else, I'm going to assume at that point it's tainted with something to be 100% safe, and then adjust my doses accordingly and go low and go slow.
Yeah. Tom, thanks so much. We are over time. You will come back next quarter because we cannot have 3 months of Dentist in the Know Humpday Happy Hour without one night with Tom Viola.
Thank you.
Because we have to do bisphosphonates. That's next. I have
yes
so many questions.
We didn't even touch that. And
no,
so
that's next. That's next chapter.
Yeah, maybe that's even before 3 months. So everybody stay tuned. Tom is a guy we are never going to let get too far away from Dentists in the Know, because I learn so much from him every time he's on. I hope you do too. I know most of you do. I could see from the comments a lot of you do. So Tom, as always, thank you.
Hey,
You
Jeff,
remember
thank
Pat
you.
Hayden?
I remember Pat Hayden sitting on the bench when Vince Ferragamo got up and led the Rams to the Super Bowl. Hey, you
Yes.
can't get a bigger Rams fan than me.
Shortest quarterback in the NFL, baby. There's a chance. There's still a chance.
5'11" and a
Never.
Rhodes Scholar. How about that? Hey, Jeff, JB and Jeff, I want to tell you real quick. I want to tell you, thank you three, you two and Chad, for what you do for this profession. So many people come up to me after I do these episodes with you and say, that was a great episode. I really enjoyed it. And I say, wow, someone's got to be able to tell you three what an impact you're having on the profession. So thank you for doing what you do every day.
Oh, thank you. We really appreciate that. Means a lot to us. And, you know, aside from the huge salary we're all knocking down doing this, that is the next best thing that we could hear. Yeah. Cha-ching.
I'll expect my envelope in the mail.
Yeah.
Yeah. All right, Tom. Thanks a lot.
We're giving away free cannabis.
Great to see you, buddy.
Thanks,
and
Kevin.
we will talk again soon, and we can't wait to do that. Be good.
Same here. Thank you.
All right.
You too.
Take
Night,
care.
Tom.
All right, JB, close us out.
I'm so geeking out. Here's the best thing about what we do every day. While it may be not for a big salary or almost a goose egg of a salary, we get to sit with some of the coolest people every Wednesday night and for an hour geek out on all the topics that you and I pay a ton of money for to consume all the time. And now, in addition to that, we get to call them friends. Like, these are people who, you know, not only do we get to spend that time with, we get to be in community. And I am incredibly grateful for that. So with that, thanks everybody for watching tonight. We'll have Tom back on very soon, and we'll dive deeper into bisphosphonates because he's promised me that topic. We wish Chad, his doggy, okay. We wish Ellen a very happy birthday. And we wish all of you a wonderful good night.
Absolutely. Great sign off. Good night, everyone. And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.